ఫస్ట్ టాపిక్ ఎవరిది? బాలదా? కిషోర్ మ్యూట్ చేసుకో అన్నట్టున్నాడు.
సార్ గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్ అమ్మా.
సార్ ఎలా ఉన్నారు సార్?
చాలా రోజులు అయింది.
అవును సార్.
సార్ మీ వాయిస్ మ్యూట్ లో ఉంది సార్ కిషోర్ సార్.
మీ సిస్టమ్ ఒకసారి లాగౌట్ లాగిన్ గా అంతే కదా?
సార్ లాగౌట్ లాగిన్ అయితే
ఇప్పుడు వస్తుంది చూడు. ఇప్పుడు అన్మ్యూట్ చేసుకో.
హలో, గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్. గుడ్ ఈవినింగ్ చెప్పు. కిషోర్ అన్మ్యూట్ చేసుకో. మన వాయిస్ కూడా వినపడట్లేదా? నువ్వు మ్యూట్ లో ఉన్నావు. ఫోన్ లో
The voice is breaking.
Computer. I lost connection.
వాయిస్ బ్రేక్ అవుతా ఉంది.
నాదే సార్.
ఇప్పుడు బాగానే ఉంది. ఇప్పుడు బాగానే ఉంది.
జ్యోతి ప్రజ్ఞని షేర్ చేయండి కదా, స్క్రీన్ షేర్.
ఒకసారి
చెక్ ద ప్రెజెంటేషన్.
yes sir.
Sir, you want me to?
Yeah.
yes. ఫుల్ స్క్రీన్ చేయండి.
వస్తుందా సార్?
వస్తుంది.
హలో సార్.
కనపడుతుంది. విజిబుల్.
గుడ్ ఈవినింగ్ సార్. సురేష్ బాబు సార్.
గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్ కిషోర్ గారు. ఇవాళ both the speakers are very like close to me, sir. I think మన జ్యోతి ప్రకాష్ sir, actually he is our pediatric cardiologist at Vijayawada, who is being in touch with our team. Next, Balakrishna is my very close junior from my like MBBS time. Both are very good practitioners. So I appreciate like IAP for giving them the opportunity, sir. Hearty congratulations. కిషోర్ గారు కూడా పాపం like 24 hours is always before they start, sir. Sir. కిషోర్ గారు కూడా పాపం 24/7 is always he is in search of good speakers. So ఎప్పుడు పాపం మా గ్రూప్ లో పెట్టి I think he is giving excellently, he is running the show, sir. So I like to appreciate him also.
మమ్మల్ని కూడా
సార్ మీరు లేకుండా
ఇన్స్ట్రుమెంటల్ సెలెక్టింగ్ కదా,
మీరు ప్రెసిడెంట్ కదా సార్. మీరు కర్త కర్మ క్రియ అంతా మీరే కదా సార్. మీరు ప్రెసిడెంట్ కదా. మీరు కిరీట్ సార్ ఇక్కడ రాలేదు సార్. కిరీట్ సార్ వచ్చారా?
గుడ్ ఈవినింగ్ సార్.
సార్ గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్ సార్. గుడ్ ఈవినింగ్ సార్. సురేష్ సార్ గుడ్ ఈవినింగ్.
గుడ్ ఈవినింగ్.
హాయ్ కిషోర్.
Hi sir.
Hi Vamsi. Hi Jyoti.
Hi.
Hi, sir.
గుడ్ ఈవినింగ్ సార్.
Hi Balakrishna. Good evening. Somsekhar sir. Sir.
సోమశేఖర్ ఫోన్ చేయకూడదా?
చేశాను సార్.
బాలకృష్ణ నీ స్లైడ్స్ కూడా ఒకసారి షేర్ చేసుకుని చూడకూడదా?
ఎస్ సార్, ఇందాక నాదే షేర్ చేశాను సార్. ఒక్క నిమిషం.
చేశారా ఆల్రెడీ? సార్
సార్ కిషోర్ సార్ నాది షేర్ అవటం లేదు. ఫస్ట్ తన
ఫస్ట్ మీదే, ఫస్ట్ జ్యోతి.
మరి నాకు షేర్ ఆప్షన్ రాలేదు.
షేర్ ఆప్షన్ రావట్లేదా?
Co-host చేస్తే వస్తుంది. Co-host చేయండి. Ask the day people to co-host.
షేర్ ఆప్షన్ వస్తుందా? షేర్ ఆప్షన్ కిందే ఉంటుంది కదా.
ఇట్ ఈస్ నాట్ షోయింగ్ anywhere. మామూలుగా కింద చూపించారు కదా.
అటు కాదు కిషోర్, డిఐపి వాళ్ళని అడిగి కోహోస్ట్ చేయమని చెప్పండి, అప్పుడు వస్తుంది షేర్ అవుతుంది. ఐ థింక్ అందరికీ ఉన్నట్టుంది షేరింగ్ ఆప్షన్.
సార్ ఇన్ఫార్మ్ చేశాను సార్.
ఓకే
ఓకే ఓకే. I think share option is available for all, I think so. All panel members. Jyoti, మీరు షేర్ నొక్కారా? అది ఒకసారి
అంటే నాకు అసలు షేర్ ఆప్షన్ చూపించటం లేదు సార్.
గ్రీన్ కలర్ లో ఉంటుంది బటన్ లేదమ్మా?
లేదు ప్రాబబ్లీ, బట్
ఒకసారి ఎగ్జిట్ మళ్ళీ రీజాయిన్ కండి చూద్దాం.
సార్ చూస్తాం.
యు గాట్ ఇట్ జ్యోతి ప్రకాష్?
సార్ ఒకసారి సార్ సపోర్ట్ అయ్యి లాగిన్ చేయమన్నారు కిరీటి సార్.
గుడ్ ఈవినింగ్ మొబిలిటీ.
సార్ సార్ గుడ్ ఈవినింగ్ సార్.
గుడ్ ఈవినింగ్ కిరీటి.
సార్
వీడియో రావడం లేదా?
వీడియో రావట్లేదా? మాకు వస్తాను మీది
సార్.
హాయ్ వంశీ.
సార్ చెప్పండి సార్.
ఊరికే హాయ్ వంశీ అంటే
అదే సార్. ఓపీ అయిపోయింది సార్?
లేదు ఉండాలి ఇంకా మధ్యలో.
అదే సార్ కదా.
ఎక్కువ బిజీగా ఉంది ఇప్పుడు.
అవును సార్ బాగా ఈ వైరల్స్ ఎక్కువ ఉన్నాయి సార్.
వచ్చిందా వచ్చిందా? షేర్ బటన్ లేదా కింద?
ఏమన్నా డిఫరెన్స్ ఉంటుందా?
కాదమ్మా, ఇప్పుడు స్టాప్ వీడియో పార్టిసిపెంట్స్ దగ్గర మ్యూట్ బటన్ ఉంది కదా, దాని పక్కన స్టాప్ వీడియో ఉంటుంది, తర్వాత షేర్ కంటెంట్ పార్టిసిపెంట్స్ అని ఉంటుంది కింద.
షేర్ కంటెంట్ లేదు, అది మామూలుగా రొటీన్ అక్కడే చూపించాలి. డైరెక్ట్ పార్టిసిపెంట్స్ ఉంది.
పార్టిసిపెంట్ పక్కన లేదా?
లేదు.
లేకపోతే కిషోర్ పంపించండి, కిషోర్ షేర్ చేస్తారు మీ స్లైడ్స్.
ఆల్రెడీ పంపించాను కిషోర్ గారికి. ఒకసారి లేదు మీరు షేర్ చేయండి సార్, కిషోర్ సార్.
Hello, doctor.
గుడ్ ఈవినింగ్ సోమశేఖర్ సార్.
Do you want to try sharing your screen?
Good evening, Shamshakar.
Yes.
గుడ్ ఈవినింగ్ సార్.
Okay. Who's the speaker, doctor?
డాక్టర్ జ్యోతి ప్రకాష్.
Dr. Jyoti Prakash, can you hear me?
Yes, tell me please.
Okay. Is your PPT open in the laptop?
Yes, it is open.
Okay. Come back to Zoom.
Okay.
At bottom, can you see share screen? Green color.
No, at bottom I don't see anything. It is showing the mute, stop video, participants, chat, reactions.
So next to chat, you can see a green color one, share screen.
Yes, sir. Yeah, routinely I used to see, but it is not showing.
Share screen or share. Have you joined using Windows or Mac?
Safari.
So namaskar.
See, I am the co-host. Now, can you see share screen?
Sureskar, same pinch, sir, same pinch, blue color.
Please don't log in from two devices. Is Zoom
Shamshakar,
application logged in
It's
your
not two devices,
laptop?
it seems.
No.
Somebody has logged in two
Dr.
mobile and
Jyoti,
laptop.
please wait, everyone. Dr. Jyoti, please download Zoom application in your laptop and then join the meeting. You need to download Zoom first.
Fine. I'll do that. 2 minutes.
Ramakrishna sir, namaskar sir. Guruji.
Namaste sir, namaste.
Guruji, Ramakrishna Guruji.
Namaste.
Namaste. We conducted our state level quiz yesterday.
Wonderful.
Successfully.
When young man is at the helm, things will be very fast.
The next round, we are thinking of elimination rounds by online.
That's correct. Online elimination shall be online only.
Okay,
right.
sir. Okay.
Because the screening just for screening and getting eliminated, no 2-3 teams shall feel bad. What you did is perfect.
Okay, sir. Okay, sir.
You are doing in ICH, is it?
Yeah, they did it in ICH only, sir. Yes, sir.
Okay, right.
Sir, or else we can start with Balakrishna, sir. First topic.
Yes.
Yes, we can.
Okay. As time is now 9:03, we'll start.
And thank you for the opportunity of sharing this session, sir. And it is one of the most popular CME which I have come across. The Iap Ap Yuva Cme, which has become more popular among all the postgraduates. And
Yes,
I'm
sir.
very happy and really thrilled to be part of your team. And here I could see Kiriti and our Guruji Ramakrishna. And of course, without MV Suresh, how can we conduct any meeting at all? And thank you, Dr. Kishore, for coordinating it. And once again, thanks for the opportunity.
Thank you, sir. On behalf of IAP AP State Chapter, I humbly welcome you to the platform, sir, IAP AP Yuva Cme, sir, because we are having close association for long years, sir. First we met in Kanyakumari Medical College as a co-examiner. From
2009, sir. 2009.
Yes, sir. Yes, sir. Yes, sir. It's very great opportunity for me to introduce you to the for this IAP Yuva Cme, sir. Because the main purpose of IAP Yuva Cme is to bring out the talents in the young generation, so that we can expose to them to the, Pedicon and all that. We are giving opportunity for 30 to 40% of speakers are from Yuva Cme, sir. So this is a very good platform for the young generation, young speakers, sir. And with this, and also I welcome our state president, Dr. M. Suresh Babu, sir. And Yuva Cme coordinator Dr. Dr. Kishore, E. Kishore, and CIP, IAP Central Executive members, Dr. Ramkrishna Moramsa sir, and Dr. Gobul Reddy, and Dr. Pawan Kalyan, and other executive members, Ratnakar, who else are there in our panel, and all panel members. So with this opening remarks, I would like to invite our president to give message to the audience. Over to Dr. Suresh Babu, sir.
Thank you. Thank you. On behalf of IAP AP State, I welcome you all to the latest edition of Yuva Cme, which is going uninterrupted and with great josh. With that josh, we have another josh today as a chairperson to this Yuva Cme, Mr. Somsekhar. It's my pleasure to introduce Dr. R. Somsekhar, chairperson of this edition of Yuva Cme. He is Professor of Pediatrics, Sri Balaji Medical College and Hospital, ex-Dean, Kanyakumari Government Medical College, Vice President, South Zone, Central IAP 2021, Honorary Secretary, IVCF and HMBA 2021, EC member, IMA Standing Committee on Child Health, past President, IAP Tamil Nadu 2019, and FIAP awardee by IAP 2018, Best Doctor Award by Minister of Health and Family Welfare, Government of Tamil Nadu. He has, for his credit, 25 publications both in national and international. So it is fortunate to have Somsekhar as today's chairman. So, and coming state conference also, I request the organizers. Anil is not there; he has not come yet, to accommodate as many members of this Yuva Cme presenters who have doing their presentation excellently. Now we'll go with today's program. To Kishore. Kishore, you can take over.
Thank you, sir. Thank you very much. Welcome all the dignitaries. Welcome, sir, Ramakrishna sir, and Ubulid, and Kiridi sir, and moderator is Dr. Rupa sir, Polo Hospital, Nellore. She has done an undergraduation from Guntur Medical College, DC Medical College, and the DNB from Rich Hospital. Now she's working as a pediatrician at Apollo Hospital, Nellore. Welcome, madam. Welcome to the. And Jyoti, are you ready? Jyoti Prakash.
It is too ready, Garu, today going to blast the screen. Double dhamaka.
Dr. Balakrishna Garu has to stop the sharing.
Yeah, sure.
So, sorry for inconvenience.
So I read one phrase today. Actually, who is an illiterate? A person who was not willing to learn, unlearn, and relearn is a real illiterate and a true illiterate.
When Dr. Somsekhar is there, it is triple dhamaka, not double dhamaka.
Sir, your presence makes the difference, sir. Paramakrishna, sir.
It's
You are
all
blessed.
over.
We're going to present now.
Jyoti Prakash.
Yes, sir.
You can share now.
Yeah, I'm sharing, but it. Sorry, went wrong. Why it is showing the privacy?
Moderator, meanwhile.
Yeah, moderator, she's ready, sir. To decide speakers, you.
Madam, Dr. Rupa, madam, you can introduce your speakers, ma'am.
Okay, sir. Sir, first Jyoti Prakash sir, Balakrishna Reddy sir.
Whoever may be, just introduce both of them.
Okay.
Meantime.
Okay, sir. Good evening to all, sir. I heartily welcome all the senior delegates and families over here. Dr. Rupa, consultant pediatrician and neonatologist at Apollo Specialty Hospitals, Nellore. And today I feel very much honored to be as moderator to this session. First of all, I would like to introduce today's speaker. The first speaker is Dr. Jyoti Prakash sir, who is consultant and interventional pediatric cardiologist at Aster Ramesh Hospitals, Vijayawada. Sir has did his MBBS from Narayana Medical College, DCH at Kaduna Medical College, DNB at Lotus Children's Hospital, Hyderabad, and fellowship in pediatric cardiology at Narayana Hrudayalaya, Hyderabad. Today, sir going to discuss the topic on tiny hearts and big challenges, that is current status of pediatric heart failure. Sir, I heartily welcome sir to the session. And our next speaker is Dr. Balkrishna Reddy, sir. He is consultant pediatric intensivist and pediatric cardiac intensivist at Andhra Hospitals, Vijayawada. Sir has done MBBS at JJ Medical College, Davangere, MD Pediatrics at Narayana Medical College, Nellore, and PICU Fellow at Apollo Children's Hospital, Chennai. Sir is going to enlighten us on how to approach a child with polytrauma. And welcome, sir, to the session. Okay, sir. I would like to start the session, sir.
Dr. Kishore, everything is Nellore's flavor of Nellore. Huh? Right from speakers to moderator to president to coordinator, everything.
Balakrishna, sir, Balakrishna did SR at Tirupati, sir.
Oh. So you want to take the right.
Yeah, sir. 1 minute. Something is.
We'll start with
Okay, sir. I'll start this then.
It can be shared to Kishore. I think that will be better.
Sir, may share just sir, Kishore, sir.
Okay, I will share you.
Yeah.
1 minute.
But Shamshekar, that quote is very good. Breastfeeding in public, sanitize your mind. Wonderful. Dr. Shamshekar, yes. That's very good message. Now you are muted.
Yeah, I'm keeping it, sir. Thank you very much. Thank you, sir.
ఏం రావట్లేదా?
If Balakrishna is ready, we can start with Balakrishna, no problem.
Start Mandara, sir.
Balakrishna?
Yes, sir.
Can you start? Oh, okay, it is coming. Yes.
Starting. Yes.
Yeah. Okay. Full screen.
Sir,
make it full screen.
Can I have control over this, sir?
Yes.
And enable editing, press cheste vastuna. Okay. Prakash, you can start now.
Sir, it's not.
You can start.
It is already shared.
Yes, sir. It's not moving, so I was just checking. Okay. Sir, you will be controlling Kishore Garu?
Yes, he will do it.
You can tell next, then he will do it.
Okay. Sorry for the interruption. So, good evening, everyone. I'm Dr. Jyoti Prakash, the consultant pediatric cardiologist. So, I'm working from Aster Ramesh Hospital from 2015. So, here I'm going to talk about tiny hearts and the big challenges, the current status of pediatric heart failure. So, I thank all the DIP members and Dr. Suresh Garu, Dr. Ambul Reddy Garu, Dr. Somshekar Garu, Dr. Kishore Garu, Kiriti Garu. I thank all the team, all the participants here for giving me this opportunity. So before proceeding this one, sir, next slide. So it's the current about the pediatric cardiac failure. So there are not much data available in India. So many centers like, sorry, yeah, please previous slide, sir. Yes, keep this slide, please. Next slide, next slide. So there are many centers, though they are concentrating on the other interventions group, but per se, the incidence of cardiac failure in pediatrics, it was much less studied. Dr. Anita Saxena from AIMS, Dr. Vijay Lakshmi from Bangalore. Very few centers have done vast research on the cardiac failure status in children and the necessity of interventions or necessity of hospitalizations or necessity of cardiac transplant, are only very few trials are available, but compared to the Western and other Europe Europe countries, sorry. Sir, next slide. If you see the overall burden of congestive cardiac failure in less than 20 years, that in pediatric age group, it is less than 1% compared to the elderly. So where it is the ischemic heart disease or hypertensive and the valvular heart diseases dominates. So there are high chances for having congestive cardiac failure, which require long-term management in adults. And in definitely we should not forget, like the malaria or malnutrition can lead to anemia, which can exacerbate or induce cardiac failure in children. And in particularly some ethnic groups, because of those the religion ethnicity, so there is high chances for vitamin D deficiency, and they can have hypocalcemia, severe LV dysfunction, and they can present with early onset congestive cardiac failure, particularly in the neonatal age group. So next slide. So out of all hospital admission, if you compare, almost 1/3 of cases are secondary to heart failure, particularly in infancy. Almost more than 2/3 of the cases are just because of congestive cardiac failure. If you compare to the same older age group, the same the scenario is majority dominates in the infant, because in infants there are high chances for the rhythm disturbance. The heart is contracting with the maximum compliance. So only the rate will be deciding the cardiac output. So any alterations in the rhythm definitely can lead to congestive cardiac failure in children. And if you compare with the causes of cardiac failure, both in adult as well as children, as I said, the ischemia or hypertension are dominating in the adult age group. In children, they are mostly the congenital heart diseases like shunt lesions, VSD, PDA, and in obstructive lesions like aortic stenosis, bicuspid aortic valves, and cardiomyopathies, they are dominating. And majority of adult failure reasons are purely left ventricle. Right ventricular involvement is many times in chronic pulmonary thromboembolism. It may be univentricular, you say, but in children it is mostly biventricular. Sir, next. So the major mechanisms. So I'm not going to teach much about the mechanisms, but I would like to more concentrate on the management part. So here briefly I'll introduce about the mechanism, pathophysiology of this cardiac hypertrophy and cardiac dysfunction. It is mainly related to two systems. One is renin-angiotensin system. The other one is natriuretic peptide system. So as all of you know that angiotensinogen is released in the renal, which is converted to angiotensin 1 and angiotensin 2. So by angiotensin converting enzyme. And this angiotensin 2 binds to the angiotensin receptor 1 at the cell surface. So it has various actions at various levels. So the majority we need is that it induces the cardiac hypertrophy, apoptosis, and myocardium. And in peripheral vessels, it causes vasoconstriction and oxidative stress, which on both way it induces the afterload, increases the afterload on the heart, which finally led to cardiac failure. And in kidneys anyway, you know that it induces the aldosterone system. So the sodium reabsorption happens at this, which again increases the hypervolemia and the afterload. And in CNS, it causes norepinephrine release. Next slide, sir. The other mechanism is natriuretic peptide system. So routinely, usually we'll have almost 9 types of natriuretic peptides, but majority are read about 3: this atrial natriuretic peptide, brain natriuretic peptide, and C type. These all routinely, usually they cause vasodilatation and they reduce the afterload and they reduce the sympathetic tone. But when it is cleared by neprilysin enzymes, then the reverse happens. So it causes vasoconstriction and increases the sympathetic tone, and it induces the fibrosis, cardiac myocyte fibrosis and apoptosis. So thereby it worsens the congestive cardiac failure. Next slide, sir. So the only advantage in pediatric is that though the majority of the cases are wide variable, means if you see adult age group, there is only 3 reasons: either coronary artery disease or hypertensive or valvular heart disease. But in children's, if you see, there are majority myocardial cardiomyopathies, genetic syndromes like Pompe's disease, Fabry's disease, mitochondrial myopathies, and the mineral deficiencies like selenium deficiency, carnitine deficiency, all them can cause cardiomyopathies in the younger age group. And even this Kawasaki, these acquired conditions like Kawasaki, Takayasu, rheumatic heart diseases, and congenital conditions like acyanotic congenital heart diseases, all can cause, but majority of the times they will have some management, like in the form of medical management or therapeutic means interventional management, but compared to adults. And that's why the mortality and morbidity are worsen in adult group compared to pediatric. So next. So coming to the etiology, so there are I just now I said that the heart is doing at maximum compliance in the newborn and in utero also. So that's why any rhythm disturbances in utero can lead to congestive cardiac failure. So usually in utero it manifests like a high drops. So we are not going to discuss much about this. So next slide, sir, please. And the etiology and symptoms, everything varies in pediatric age group. It depends on the age of onset. So in newborn period it is different, and in newborn period also on day 1 and in the first week of life, and in postnatal, post-neonatal period and post-infantile period and toddler, and everything it depends. And the majority of the times it is rhythm disturbances in first week of life, and in case of like infancy also, because of maximum compliance of the heart. And on day 1, that is particularly perinatal asphyxias, the systemic AV fistulas like vein of Galen malformations and rhythm disturbances which started in utero can lead to congestive cardiac failure. And like in case of Epstein's anomaly, AV canal defects, you can have the rhythm disturbances in utero itself, and they might manifest immediate in postnatal life. So next one. And in first week of life, the drug-dependent cardiac lesions are dominating. So like hypoplastic left heart syndrome, coarctation, even TGA with intact septum, adrenal insufficiency, and critical aortic stenosis, pulmonary stenosis. They will be dominating the congestive reasons for congestive cardiac failure. And if you don't treat in immediate in the newborn period, definitely they are going to succumb. And in late neonatal age group, so particularly in preterms, the PDA is the dominating lesion. So usually it can manifest within first 72 hours. And if it is hemodynamically significant PDA, definitely the child will have in the first week of life itself. But sometimes they might tolerate, and because of the associated PAH conditions, it will be the shunting across the PDA might be less. Once the pulmonary vascular resistance comes down, usually it will take like 3 to 6 weeks. Once that pulmonary vascular resistance comes to the normal adult values, so the shunting across the VSD and PDA worsens, and even AV canal defects. So that's why it will cause more of pulmonary increased pulmonary blood flow. Thereby, it increases the congestive cardiac failure. The other reasons in late neonates is truncus, unobstructed TAPVC, aortopulmonary windows, and in a little more age group where because of the coronary steel, after 6 weeks of life, same thing, because of PAH, usually it will be because of normal pulmonary vascular resistance, there will be less coronary steel in the first 6 weeks of life. Once that PAH normalizes, the increased coronary steel leads to left ventricular dysfunction, and they can present in the late neonatal period. Next, sir. And anyway, in older children, majority of the times, the congenital heart diseases like moderate sized VSDs, moderate PDAs, and infective endocarditis, rheumatic fever, cardiomyopathies, and other metabolic reasons also can lead to. And in little older children, the rheumatic fever, Kawasaki and Takayasu also can present at the congestive cardiac failure. Next, sir. So coming to the symptoms, so there is based for clinical classification, there are many methods available. So routinely in the adults, NIHA classification will be followed, but in children, this is little different. Routinely we suggest ROS classification. So it is not much different with the NIHA, but it is like a similar one. So in class 1, there won't be the child will be asymptomatic with some amount of structural heart disease, and in class 2 there will be mild tachypnea or diaphoresis while feeding, and in children it is dyspnea on exertion. And in class 3 there will be marked tachypnea or diaphoresis with the feeding, and that feeding time also many times it prolonged, and because of these intermittent feeding, intermittent success cycles, there is a chance for growth failure, which results in which worsens the heart failure, and there is a marked dyspnea in case of children, older children. And if it is addressed, it is class 4. Same NIHA classification as you all read. There is with the little modification based with clinical and structural modification classification of heart failure suggested by AHA. It is stage A, where means at a high risk for heart failure, but they won't be having any structural heart disease. Like in case of some chemotherapeutic agents, the child is on anthracyclines or something which can have cardiotoxicity. But if you screen the child will not have any structural heart disease. Those are considered as stage A. In stage B, the child is having some structural heart disease, but which doesn't have any signs and symptoms, like in moderate sized or small VSDs and all. So where the child will have some amount of structural abnormality or rheumatic heart disease with mild mitral stenosis, mitral regurgitations and all, where you will have structural abnormality, but there won't be any signs and symptoms. And stage C, like in myocardial disorders and all, where you can have structural heart disease with prior symptoms and now ongoing symptoms. And stage D is refractory, all the structural heart diseases which are resistant to or routine medication are considered in stage D. Next, sir. Next. Okay. So if you see this, these are the routine manifestations in infants, toddlers, school age. No need, sir. We'll skip on this anyway, because many of you are aware about the symptoms in at each level. So the infants will have failure to thrive on persistent tachypnea, feeding difficulties, and toddlers will have poor effort intolerance, decreased activity, and poor appetite. And in school age group, easy fatigability, effort intolerance, and other on examination anyway you will have hepatomegaly at each level. And little older children, you can have the history of chest pain, breathlessness, and because of congestive hepatomegaly they can have pain abdomen, and because of GI intolerance or gastric congestion they can have GI symptoms as well. Next, sir. Next, sir. Next. So yeah, okay. So finally, after diagnosis, we are more concentrating in this session about the diagnosis as well as the management part. So if you see the routinely the management part, the diagnostic part is much evaluated. More recent imaging modalities, they give perfect idea about the diagnosis of congestive, the reason behind the congestive cardiac failure, so that our treatment will be targeted. So as a first line modality, the chest X-ray is the first preference always. So the chest X-ray is mainly to look for the cardiomegaly, but never ever judge a patient ruling out cardiomegaly. If there is no cardiomegaly, that doesn't mean that there is no cardiac failure. Always suspect when there is clinically the symptoms are suggestive of cardiac failure. Definitely it should be, but never like in case of obstructed TAPVC, in case of congenital mitral stenosis or core triatrium, though you don't have any cardiomegaly on X-ray, definitely the child will have features of congestive cardiac failure. And this cardiomegaly, cardiomegaly is decided by more than 0.6% if it is the CT ratio of more than 0.6 in infancy and 0.55 in children. It is indicating that cardiomegaly is there. And the chest X-ray other uses are like it is mainly for the plethora, whether the child is euvolemic, hypervolemic, or oligemic. And in case of right ventricular and left atrial enlargement, it is preferred to have lateral X-rays. Next, sir. The other modality is ECG. So it is mainly to see for the chamber enlargement and in suspicious rhythm disturbances in tachycardiomyopathies, and in case of prolonged QT syndromes. ECG always has significant role before labeling some other abnormality. And whenever you have a doubt that there is a significant LV dissection, but the child doesn't have any other etiology found, so ECG will help you in guiding that the presence of alkapas like pathological Q waves, abnormal Q waves like in lateral leads in lead 1 and AVL. If they are present, it is significantly supportive that alkapa, particularly in infancy and up to 5 years of age, because majority of the times there is no other reasons. So yeah, if at all PGs are there, okay, I will go with this. So and another is the advantage is tachyarrhythmias. So you can see that is anybody noticing this, sir? Hello. Hello, sir.
Jyoti Prakash.
Yeah. Anybody noticed the delta waves in this ECG? So if you see that V4, V5, V6, there is pre-excitation. The PR interval is short, and there is delta waves are there. Are you able to see, sir?
Yeah.
Yeah. Okay.
With your pointer, you can show them. So,
yes, sir. In V4, V5, you can see that there is a pre-excitation. It is clear. It is clear. It is there in L2, L3 also, L1 also, but it is more clearly prominent in V4, V5. So whenever you have a child with congestive cardiac failure, in between you are seeing that this type of ECG, always think that there is some amount of SVT, frequent SVTs is having WPW syndrome, should be suspected. Next slide, sir. So it's this is the bradyarrhythmia. So it is a complete heart block. You can see that there is no correlation between the P and QRS complexes, and you can see the heart rate is less than 50. So this conduct a complete heart block where you can have this. The ECG definitely signifies the abnormality, and it provides us the indication for pacemaker. Next. And anyway, echocardiogram is the gold standard, and it is much useful to confirm the structural underlying structural pathology. It is useful in differentiating between the great vessel anomalies, and it gives the both left ventricular and right ventricular function. So how much is the ejection fraction, how much is the fraction shortening, and is there any associated pericardial effusions or pleural effusions? So definitely majority, more than 90 to 95% of the cases, the congestive cardiac failure can be diagnosed in echocardiogram itself. And is the newer echocardiogram machines, they can show you the rhythm disturbance, rhythm abnormalities. Is there any complete heart block? So echocardiogram will be the gold standard always. Whenever feasible, the patient should be, the child should be undergone echocardiogram at the earliest possible. So this is the 13 months child with presented with history of breathlessness, and he had history of fever with the rash almost a month back. So then he presented with fever, breathlessness. So when we did clearly, I think my marker visible, sir. Sir, my marker is visible.
Yes, yes.
So you can see that there is a giant coronary aneurysm, which with inside there is a clot. So it is a purely a Kawasaki disease, which is having giant coronary aneurysm causing LV dysfunction. So which is responsible for the congestive cardiac failure. Next slide, sir. So there is a fetal echo. Yeah, okay, leave it, no problem. So other newer imaging modalities like the lab parameters are biomarkers like cardiac troponin, CPKMB, BNP. Next slide, sir. So BNP and NT-proBNP and mid-regional. So usually the normal range is less than 35, the BNP levels, the brain natriuretic peptide. If it is more than 100, should be considered as a significant for congestive cardiac failure. And this BNP and the NT-proBNP levels always, they differentiate between the respiratory distress, whether it is a respiratory or cardiac. If the BNP and NT-proBNP levels are significantly elevated, it is suggestive that it is more of cardiac than a respiratory issue. Next, sir. So other imaging modalities like cardiac CD, when when the windows are poor with the echocardiogram, and when you are not able to diagnose something else, like in case of Kawasaki disease and Takayasu, you can go for the other imaging modalities like cardiac CT, MRI, and coronary angiography. Diagnostic angiogram. So, but majority of the times in children, because they will have good chest windows and all. So echocardiogram alone can give the benefit much better data. The newer cardiac MRI is giving that ventricular volumes, means ventricular function, how much it is the end systolic volume and diastolic volume of the left ventricle. So these, if at all, whenever you are planning that, it's a dilated cardiomyopathy or hypertrophic cardiomyopathy, in those conditions, and if you are suspecting any fibrosis or any non-compaction cardiomyopathies, in those conditions, the cardiac MRI is very much useful. So, and other newer modality is whole exome sequencing. I think majority of you are following, I think, because of newer this one whole genome sequencing, exome sequencing, many of them are practicing, and particularly when they are cardiomyopathies, even congenital heart diseases, many times it gives us two reasons. One thing it is the inheritance, the other thing is the diagnosis, and three is prognosis. So for all these purposes, the whole exome sequencing is important. And if you see the cardiomyopathy channels, the panels, there are more than 210 genes which are proven one, and some still there are some variants of unknown significance still are there, but the detection rate also it came to up to more than 35% from 20% in case of cardiomyopathies. So usually the hypertrophic cardiomyopathy, majority of the times it is inherited as autosomal dominant, and it is the main genes behind this beta myosin heavy chain genes and cardiomyosin binding proteins. And whenever you are having that the mutations in LMNA and phospholamine, definitely they have very, very poorer prognosis. Either they go and they need for transplant or ICDs. And dilated cardiomyopathies, if you see that less than 1/3 are hereditary, more than 2/3 they have some in children, particularly they're post-viral or some myocarditis induced or something else will be there. But in case of 1/3 of cases, you will have some abnormal genes, particularly linked to cytoskeleton. And most frequent we see is titin, lamin, and desmin. And ARVC routinely we miss, but majority of the times it presents with sometimes cardiac sudden cardiac arrest, but they are also mostly hereditary. Whenever you are suspecting some familial inheritance, always you should rule out ARVC, and they are mainly desmosome inherited mutations. And DNA analysis for mitochondrial myopathies, particularly when you are suspecting in first degree relatives. So DNA analysis should be done. So other investigations like thyroid function tests and serum ferritin levels, particularly in thalassemia patients who requires frequent transfusions, and serum thymine levels nowadays, though it is reduced, but still in on and off cases we used to see that thymine deficiency leading to congestive cardiac failure. And one of the other, though they are adult cardiologists, they routinely start carnitine supplementation for dilated cardiomyopathies, but the cardiomyopathies are more common in pediatric age group, this carnitine deficiency leading, particularly between 4 to 7 years. And whenever this one carnitine assay is low, it indicates that it is a reversible cardiomyopathy. Sometimes child might need a prolonged time, but definitely the cardiomyopathy is well responded to with the protein supplementations. So, and whenever you are suspecting metabolic abnormalities, you have to do all this lactate, blood ammonia, other metabolic screening methods. Next. So coming to the major part of our session is about the newer modalities of congestive cardiac failure. So initially they used to say that because the majority of the treatments what we are following here is just 2 decades before only. That means now 2 decades before only it is like supportive management, pull the child to certain level, certain age, and then identify the reason, then do that. But from last 2 decades, there is because of much available of newer modalities, newer investigative modalities, newer treatment modalities. So now the target is cause-specific treatment. First, identify the cause, treat the cause, then start supporting the child. So, next slide. So for that, I'm going to give some. Is any pages available here to interact? Sir, keep this one, sir. Okay, here is a 10 days old child brought with poor feeding, diaphoresis, and subcostal retractions. And if you clinically see the child is having congestive cardiac failure, and echo-wise, he is having severe biventricular dysfunction. Next slide, sir. So if you see that heart rate, the ECG of this child, there is ST changes are there, and the QT interval is, sir, next slide. Yeah, it is around 520. So it is definitely prolonged for this age. So the prolonged QT interval, one of the most common acquired cause of prolonged QT interval in children is hypocalcemia. So this child, actually, you can see that the baby name I just mentioned for the same reason. So it is a Muslim population which are having this Kurda system. So the child is mother is having vitamin D deficiency. So it's for both mother and baby done. So the vitamin D levels are much lesser, and calcium levels also much lower side. So after starting inotropy and calcium vitamin D supplementation, the ejection fraction improved significantly from 15 to 55%. So another child extremely low birth weight. So as you all expected, the child is having significant hemodynamically significant PDA. So initially started on pharmacological method, but never ever don't wait till that 45 days. And so because again, after once if you develop the bronchopulmonary dysplasia, sometimes it might be lifelong even. So this child underwent a surgical ligation of PDA and could extubate successfully by next 48 hours. Next, sir. So here one more case, 27 years primary mother, so brought at 34 weeks by pediatrician, by obstetrician. So suspected some abnormal rhythm. So before it was not there. So then next slide, sir. Yeah. So here you can see that the heart rate, you can see in the second slide, right-handed one, the heart rate is around 294, means approximately more than almost near to 300. So this is nothing but the fetal SVT. Next slide, sir. So we asked the radiologist to see the expected weight of the child. So he mentioned it's around 2.5 kgs. So then we electively induced the child born with 2.6 kgs at 34 weeks. So once adenosine given, you can see after adenosine that there are flutter waves are seen. So it's a atrial flutter. So initially the child is stable. So we tried with the digoxin infusion. But as the child, the hemodynamics are deteriorating, cardioversion attempted and later managed with amiodarone infusion. Next slide.
Sir, excuse me, Sir Jyoti Prakash, sir. We are running out of time, sir. It's 9:45.
Okay.
Just to remind you. Sorry, sir. Sorry to interrupt you.
Maybe it takes another 10-15 minutes. Because we are at the start of treatment.
Okay.
I'll try to simplify as possible. Okay.
Jyoti Prakash, you have to finish in 5 minutes because another speaker is there.
Yes, sir, yes.
It's already 9:45.
Yeah.
Okay.
Sure. So then another 14 months child. So we'll skip off this example, sir. Sir, next one. Next. Okay. So yeah. Next also. Next. So these are all cause specific treatment. So whenever you are suspecting some cyanotic congenital heart disease, cyanotic, or whatever the reason which are responsible, so always treat the underlying cause first, then support the baby. Next, sir. Next. So whenever you are suspecting rhythm abnormalities, you have to this one. So you have to do sorry, back. No, yes, here, back. Okay. So before labeling that the child is having some abnormality, so always better to first label the child with some abnormal, then treat the target specific, then supportive management should be initiated before so that you'll have better more outcomes. And certain causes of myocardial dysfunction in children, so like mayoral myocarditis, carnitine deficiency, hypocalcemia, Takayasu, this all can cause myocardial dysfunction in children. Next, sir. So there are, though some people will argue that there is no role for IVIG infusion, but some Cochrane reviews in 2015, they showed them benefits with immunosuppressants, IV immunoglobulins and other. So, but in adults population, if you see, if you compare the viral myocarditis, there is not much significant role about this. But there is better outcomes with this IV immunoglobulins. Many children have, even we have one case which start with 10 to 15% IVF, and immediately after 48 hours of IVIG infusion, the child improved to 50 to 60%. Next, sir. So another thing, if any ECG which suggestive of left ventricular hypertrophy with tall dented T waves, so it's short hearted, definitely suspect carnitine deficiency, and because carnitine deficiency is the one of the cause for reversible cardiomyopathies. Next. So now comes to the supportive management. So sometimes if the child is not having any diagnosis, or if we are not sure about the status of the child, or if he is not ready for the procedure, then you have to give supportive management. So the supportive management depends whether the child is acutely ill, means whether he is hemodynamically unstable or stable. So in unstable children, always the diuretics and inotropy are the first choice. So the recommended diuretics, sir, please, before there are in children is furosemide. So furosemide can be given in continuous infusion or intermittent boluses, because to avoid hypotension and majority of metabolic abnormalities, it is better to use always as a continuous infusion, like 2 to 4 mg per kg per day you can give. So the furosemide gives relief from the pulmonary, systemic and venous congestion. The other newer modality is torsemide, which has longer half-life, because furosemide may require frequent times, because its maximum action is 4 to 6 hours only. So the torsemide, it has longer half-life, can be given for twice a day, and it has high degree binding effect, and it has some anti-aldosterone effect, so which is helpful in myocardial fibrosis. Next one. So other added drugs can be the thiazide diuretics, because whenever you are not able to achieve the significant diuresis with loop diuretics alone, so you can add thiazide diuretics. Next, sir. So, okay, next. So the next line of management is by inotropy. So that routine inotropes we suggest is dopamine, dobutamine, adrenaline, milrinone infusions, and levosimendan. So if you see that dopamine, they are acting through sympathetic system. The newer drugs like milrinone and levosimendan, they are having much beneficiaries. And whenever you are using some beta blockers and all, because of potential arrhythmogenicity, the beta agonists are now withdrawn. So the milrinone and levosimendan are the better choice whenever children, and they have longer half-life compared to beta agonists. Next, sir. And afterload reduction. So the other in acutely ill patient, the other target should be afterload reduction. So it is attained by reducing the systemic vascular resistance. So thereby you increase the stroke volume and you will reduce the regurgitant fraction and shunt fraction in certain conditions. So thereby we can improve the cardiac output. Next. So mainly these are indicated particularly in case of shunt lesions and in case of valvular regurgitation and whenever there is LV dysfunction. But this afterload reduction should not be attempted when there is significant outflow tract obstruction like in mitral stenosis, aortic stenosis, and coarctation. So the routine afterload reducers we used are so first choice is phosphodiesterase inhibitors, milrinone, and other is nitroprusside, nitroglycerin. But nitroglycerin only is a predominant venodilator. It is to be added as an adjuvant, not as an isolated one. Okay, so you know that the milrinone is having very significant advantages over other inotropes. It improves at every level. It has the positive inotropy, positive lusitropy, and peripheral vasodilatation and even pulmonary vasodilatation. So all the significant effects took milrinone as the first choice in case of acutely ill, hemodynamically unstable child. Next, sir. Next. So the newer levosimendan also is available. Actually, it is much read in much less tried in children. But above 7 years, there are significant trials done in levosimendan. Less than 7 years also, there are trials done. But still, we need to have this one. And particularly when there is a patients with frequent hospitalizations, particularly in cardiomyopathies, in weekly doses of levosimendan also is helpful in improving both cardiac hypertrophy, means cardiac remodeling, and need of hospitalizations. And whenever child is sick, definitely don't wait till the child falls. So always support with mechanical ventilation, reduce the work of breathing. And sir, back, sir. One more. Yeah. So next, the chair when once the hemodynamics stable. So the intermediate or long-term management will be like OP basis, where still the diuretics are the first choice. Next slide, sir. So if you see that AC inhibitors, beta blockers, and mineral receptor active receptors are the first choice. They have class 1A indication. Next one. So anyway, diuretics, you know the doses. I'm not going to deal much with this one. Next, sir. So, sir, please one slide back. Spironolactone. Back. Yeah. So because spironolactone, because of its anti-aldosterone effect, it is the spironolactone also has significant role in congestive cardiac failure. So that's why it should be always mixed with the furosemide. So the furosemide spironolactone should be in a combination of 40:100. And this one in neonates, it is 1 to 3 mg per kg in 2 divided doses, and children it is up to 4 mg per kg you can give. And this is because it has synergistic effect, but only the majority of the times we see that in adults and males, they will have that gynecomastia. So that's why routinely we avoid in adults and males, where eplerenone or other amyloid or triamtrin are helpful because they are the potassium sparing diuretics. Next one.
Sir, 2 minutes, sir. Another 2.
Okay, the major part comes now only. Other major modalities are AC inhibitors and beta blockers. So AC inhibitors, definitely they act at every level of cardiac myofibrosis and apoptosis level. So AC inhibitors are the best choice because they inhibit the sympathetic renin-angiotensin activity. And because of its potential adverse effects, cough and angioedema, the angiotensin receptor blockers are available. So like losartan, valsartan. And another newer modality is angiotensin receptor neprilysin inhibitors. So there are many trials done for that, but only sacubitril is the one which is accepted. So this it inhibits the neprilysin, so that it prevents the clearance of the natriuretic peptides. So thereby improves. But only a disadvantage with the neprilysin inhibitors is it activates the angiotensin mechanism. So that's why it always should be in conjunction with angiotensin receptor blockers. So sacubitril is routinely mixed with valsartan. It has much significant, more than 30 to 50% significant improvement in mortality as well as morbidity, and it also prevents cardiac death, sudden cardiac arrest. Whereas AC inhibitors does not have shown any significant effect on sudden cardiac arrest, but improves mortality and morbidity. But ARNI showing benefits also. Next, the other choice is beta blockers, but they are indicated only when the LV function is more than 30%. They have negative inotropic effects, so they reduce the heart rate and improves the cardiac performance and improves the myocardial oxygen demand. The other newer device, sir, come to 3 slides before. One more. So this one, sorry, it is, I think, okay. This is called cardiac resynchronization therapy. So here we introduce 3 leads. One into right atrium, another one into right ventricle, another one into coronary sinus, so that the ventricles will be paced at our necessity ranges, so that it improves the cardiac remodeling. These are this is called CRT methods. These are very much useful in decompensated patients, where you have to manage them, and when you feel that it is reversible treatment etiology, definitely the CRT gives much life for the patients. Next one, sir. So one before. So other one is LVADs, that is artificial heart. So there are more than 1 lakh users in Western countries, but in India there are much tried, because the cost itself is more than 75 to 90 lakhs. And the Frontier Lifeline Hospital has done many research about this, and it is showing that the cost will be less than to 30 lakhs itself. So next, and other one is cardiac transplant. So it is started in 1994 in India, but there are many challenges with this, but because the children's the cardiac ratio to adult one, whenever the specimen, donor specimen to recipient specimen, the heart ratio might be varying, because it may not be suitable for 20 kg baby, the 60 kg patient heart. But still, there are many newer modalities which are available, and there is no need of ABO incompatibility. So there are no many centers has started doing in India, almost like 14 centers in India doing cardiac transplant. Only issue is there are limited studies, and definitely compared to adults, they need induction therapy. Like in adults, only maintenance is sufficient, but in children, the induction plus maintenance both should be there. And there are not much graft rejection reasons in pediatrics. It is varies with the adult group. So there are so those things should be done. And the maximum half-life, the life of can be provided with cardiac transplant is till now it is 14 to 17 years only. So probably, hopefully, the cardiac transplant might evolve much better, and child much needed children get cardiac transplant. So thank you. Sorry for the delay. So because
thank you, sir.
It's a vast topic, so I thought 30 minutes may not be sufficient. But still, I try to cover the maximum possible one.
Thank you, sir. Thank you, sir. That was very informative and very nice presentation, sir. Very elaborated. Thank you, sir. Thank you, sir. Any questions from the participants, sir? I would like. Please.
We will take questions after second presentation.
Okay.
Because he is waiting.
Okay, sir. Okay. Then I'd like to invite the second speaker.
Am I audible, sir?
Yes.
Okay. Thank you everyone for giving me this opportunity. Iap Yuva Cme and Iap Ap State. So going straight away into the topic. So today's topic is approach to a child with polytrauma. So most of
Increase the volume of your microphone, Bala.
yes, sir.
Just you come forward just little bit.
Now I am audible, sir.
Yes.
So going into the topic, approach to a child with polytrauma. So we had this question, whenever we see the polytrauma child, what guidelines to follow, what guidelines to do. So it's simple, just follow this advanced trauma life support guidelines. But why should we do that? Is the first question. So why should we follow the advanced trauma life support guidelines? So they are simply categorized into, initially when a child comes to the ER, whenever you see the child with polytrauma, hit by lorry or when there is multiple accidents involving like.
Balakrishna, you make it full screen.
Okay, sir. Sir, ఇప్పుడు సార్
లేదు అట్లాగే ఉంది. No, you are out.
Sir, 1 second, sir. Now, sir.
Now also it is just you have this icon in this third icon in the bottom.
Balakrishna garu, next to 69%.
Okay, sir. 1 second.
Down, you can click there.
Suresh,
Sir, చెప్పండి.
how about postponing to next session? If Dr. Balakrishna Reddy is okay with that, because it's already 10:05 or so. No, not for me.
Yeah.
You may consider, Kishore and Suresh may consider.
Now Kishore. Now it is full screen, Bala.
Okay, sir. Thank you, sir. Shall I continue, sir?
Yeah.
Okay, sir. So why should we follow the guidelines of ATLS? So basically, they are simply categorized into preparation and triage, primary survey, resuscitation, adjuncts to primary survey and resuscitation, secondary survey. Then you do the adjuncts to secondary survey. Then followed by post-resuscitation monitoring. So why we need to do all this? So simply whenever your child comes to ER, you need to categorize the things. So, but what is this primary survey? What is this secondary survey? I'll be explaining in detail. So what is a primary survey? Usually whenever a child comes to the ER, so what you're going to see, usually follow the pulse assessment triangle. So pulse survey, airway, breathing, circulation, disability, exposure. So what is the difference between the primary survey in the ATLS and the pulse assessment in the. So when you're doing the airway maintenance, you need to do with the restriction of cervical spine. That is the most important part. What is the difference between the pulse and ATLS guidelines? Then when you're taking care of breathing, you need to take care of ventilation itself in the primary survey. Then you need to do the circulation along with hemorrhage control also. Followed by disability, you need to assess the neurological status and environmental control. So basically the difference is you need to take care of cervical spine, you need to control your ventilation part, and you need to do the hemorrhagic control there itself, followed by environmental control. So what are your adjuncts to primary survey? So whenever straight away you do this part of taking care of ventilation, your breathing, your circulation and everything, straight away you have to go for C-spine, CT scan, pelvis X-ray, or you need to go for diagnostic peritoneal lavage or EFA scan. Followed by you need to go for ABG, pulse oximeter and other BP monitoring. So what is the secondary survey? Your secondary survey will not begin until your primary survey is completed and your all resuscitate areas are well established. Then only you need to think of secondary survey. And you should make sure that patient is demonstrating the normalization of vital functions. So what is the secondary survey? As you know, directly I'll go to the physical examination. So you have to have 3-4 people at a time for a trauma case. So one should be standing at the bedside taking care of airway. The other will be taking care of circulation. So you have to call for help. Then the other 2 people will be taking care of. They'll be going from head to toe examination. So one will be standing at the foot, one will be standing at the head side. So they will be measuring head and skull, maxillofacial, neck, followed by chest, abdomen, musculoskeletal, tubes and fingers in every orifice. So that is the difference between this thing. So let's go to the case scenario. So I hope everyone it's clear. So we need to follow ATLS guidelines. You need to take care of primary survey where you have to make sure you need to take care of the cervical spine, breathing with ventilation, and you need to take care of hemorrhagic control also. So this is a case scenario, 10-year-old male child brought to ER with elite history of RTA, hit by car while traveling on bike. He was brought to our hospital at 108. On arrival in ER, child is complaining of mild neck pain. Rest, no other complaints. So initial assessment triangle is completely alert. What is physiological status? Stable condition, nothing to be done. So going to the primary survey, as I told you, you need to, the difference between is airway and C-spine is done. It is maintainable. Breathing wise is very comfortable. Normal respiratory rate, saturations are completely normal. Circulation and breathing, as I told you, heart rate is normal. CRT is good. Blood pressures are normal. Disability GCS is 15/15. But on exposure, if you check, there is right thigh swelling present and multiple abrasions and lacerations on trunk and legs. So what you're going to do? So child is having neck pain. Definitely you need to put cervical collar. So how you assess a trauma child? So is it necessary to insert a cervical spine collar whenever a child comes to ER in a trauma condition? Definitely yes. Because cervical spine injury, what you feel is very uncommon, but the problem is allowing excessive movement of unstable cervical spine injury will actually lead to severe morbidity. That is the reason where they tell you initially put off the cervical spine, but there are indications of when to put the C collar. Most cervical spines can be cleared clinically. So as I told you, foam collars are recommended. Hard collars. So when you have to insert a cervical spine, what are the high risk mechanisms of this injury? So simple. Whenever you are on the motor vehicle, if there is a head-on collision, rollover, or improper restraint in a motor vehicle collision, or if the fall is more than 3 meters or twice the patient's height. In all these conditions, there is high risk of cervical spine injury. So whenever you see such conditions, straight away go for C-spine collar. So what are the concerning examination findings? So whenever you see there is a cervical spine tenderness with significant neck pain with restricted movement, or if you feel that there are other significant injuries, or if the child uses hand to support head or neck, or if it is traumatic torticollis. So if you see any of these concerning examination findings, again, you need to go straight away for collar. So this is the C-spine working algorithm. So I'll just try to simplify it. So if your GCS is 14 or 15, so if the child complains, as I told you, if there is limited cervical range of motion, neck tenderness, unable to maintain, or if you feel any other injuries are there, if any S is there, straight away you take X-ray and you can go for C-spine this thing. If you feel the GCS is 9 to 13 or GCS is less, if there is no improvement, straight away go for CT spine. So if you go for CT spine, anticipate that patient will improve. If not, straight away you need to go for MRI and clear the C-spine. So problem is, so whenever you see GCS of 14 or 15, if there are any abnormal signs, put C-spine collar. After that, you can get the C-spine clearance. If you feel GCS is 9 to 13 or less than 8, straight away go for CT scan. So this is how you apply the collar. So you need to measure the distance between the base of the chin and suprasternal notch, followed by you need to select the appropriate size collar, followed by you need to slide the collar by lifting the patient's head slowly until the adhesive Velcro strap is visible. So after that, you need to mold the collar and ensure the patient's chin actually rests on the top of the collar so that they are able to open their mouth. So this is how you apply the collar. So what is C-spine clearance? What are other techniques? Manual technique, hard collar. You can use even saline bottles, sandbags, head and chin straps are also there. If you don't have ready hard collar available at our unit. So this is a manual inline stabilization. Even you can do that by one person standing at the bedside, and you can see you're holding at the collar level. Even you can do that if you don't have the C-spine collar. So these are the hard collar. Please don't use this soft collar. As you can see here, the hard collar is applied to the base of the chin so that the patient will be able to open his mouth. So on reassessment after 1 hour, the same child, airway and C-spine actually is now not maintainable. Breathing and ventilation, respiratory rate, now child is tachypneic. There is right side decreased right entry, child was having stridor, retractions, saturation 92% in room air. Circulation wise, the heart rate actually increased from 100 to 142. Now the pulses are low, peripheries are cold. CRT is 4 seconds, and definitely there is low blood pressure. If you go to disability, GCS is 12, but still pupils are equal, GRBS is normal. As I told you, there is still right thigh swelling and multiple abrasions on laceration on trunk and legs. So what your interpretation? Child is definitely having respiratory distress, hypotensive shock, and because of the shock, child is having some primary cerebral dysfunction. So what should be the approach now? Because as we told, the child came normal, child had neck pain. So as per the guidelines, we have followed because the child was having some motor vehicle collision. So we have followed, we have inserted the C-spine collar. But why this part? So what are the causes for desaturation? What are the causes for the shock? And what are the causes for drop in GCS? And does this child require CT scan brain now? So what are the causes for desaturation and shock and drop in GCS? I'll be discussing in the coming slides. So airway maintenance, as we all know, we need to do this position. So clear the secretions, oral airway, laryngeal mask airway, SOS intubation. So coming to the breathing part. So as I told you, we got the chest X-ray done. The cause for the desaturation is the child was having right side pneumothorax. We have inserted the ICD and connected to water seal drainage. We have started on O2. The ABGs was done. There is a mild respiratory stenosis with lactate of 3.5. So what are the causes of shock? So whenever you see the shock in a trauma patient, it can be any of the three. So it can be either hypovolemic due to bleeding. It can be obstructive because of any cardiac tamponade or hemothorax. It can be neurogenic or spinal cord injury. So if it is neurogenic shock, how you will differentiate what type of shock it is and how to identify the exact cause is the main part. So how you are going to differentiate? If it is neurogenic shock, there is injury to the cervical spine, there will be bounding pulses and wide pulse pressure and load as well. But in our case, here the CRT is prolonged, pulses are low volume, and child is in compensated shock. So definitely neurogenic is ruled out. Is it obstructive? Can be, still not ruled out yet. But how to rule out the obstructive shock? The only way you can rule out the obstructive shock is if it is a cardiac tamponade, you will be seeing low systolic blood pressure and narrow pulse pressure. But how you're going to rule it out? Only by doing the X-ray and 2D echo. So if you do the 2D echo or EFA scanning, you should be able to rule out if there is any obstruction. So if it is hypovolemic, it is due to bleeding. But how you come to conclusion in this particular child? So as I told you, go to the primary survey. So primary survey, what we did, airway wise, we have made sure that child had put cervical spine. We did the clearance of the C-spine, followed by breathing. We have cleared the ICD and pneumothorax has been cleared. Coming to the circulation, we need to do the circulation along with the bleeding control. As I told you, the child was having abrasions and lacerations. So we did the EFA scanning for this child along with the 2D echo also. So the EFA scanning, actually, we are able to identify the source. There's the collection in the abdomen beneath the liver. So child was in compensated shock due to hypovolemia, due to blood loss in this particular child. So we are given 20 ml of fluid bolus. We have given another unit of PR, 1 unit of PRBC. We immediately involved the pediatric surgeon. We got CECT abdomen and it was showing actually grade 2 liver laceration. So pediatric surgeon opined to keep the child NBM, close monitoring of abdominal girth. Currently, no active intervention is required and monitoring of serial left is died. So what is the role of EFA scanning and what you will do in the EFAST? So whenever EFAST is nothing but extended focused assessment of sonological this thing. So what you're going to see, you can see thoracic where you will be seeing pericardium along with your cardiac function, and you can see if there is any hemothorax. So pericardial, again, you will be seeing if there is any collection, followed by you need to see for perihepatic and perisplenic. Usually they are the regions where you will have some collection in case of trauma, and you can do pelvic this thing. So how to do the bleeding control? So any injured patient in a trauma child, if he is cool to touch and tachycardic, he should be considered to be in shock until proven otherwise. So the presence of a shock in a trauma patient, you need to actively involve the surgeon immediately. So definitive control of hemorrhage and restoration of adequate circulating volumes are actually the goals of treating the shock. So I just simplify this diagram. We have to have taken from the ATLS classification of hypovolemic shock. So in our child, the heart rate was high, blood pressure was low, pulse pressure was low, and definitely he was tachypneic. So it can be class 3 to moderate. So if you feel that if the child is having heart tachycardia with low blood pressure with acidosis, need of blood product should be very high. If you feel the approximate blood loss is more than 40%, blood pressure is very severely low, child is having so much of significant urine output, significant acidosis, you need to initiate the massive transfusion protocol. There is no time frame. You have to initiate very immediately. So we had recently one child who came into the ER with complete shock. So she was having severe respiratory acidosis with metabolic acidosis, complete shock. So initially we again fluid bolus. So as I told you, the child was fitting into class 4 because he was having significant metabolic acidosis. GCS was very poor, no urine output. So I have to initiate massive transfusion protocol in the ER itself. So how you respond to the initial fluid resuscitation? So as I was telling you, if there is a rapid response, if your vital signs are normal, need for blood products is very low, need for operative intervention possibly. But if there is a transient response, then you need to make sure early presence of surgery is yes, need for operative intervention very highly likely, and blood preparation should be type specific. So need for blood, very, very high requirement is there. So what is a massive transfusion protocol? Very simple. So you need to make sure you give PRBC, FFP, platelets, and tranexamic acid. SOS, cryoprecipitate should be included. So you need to tell to the transfusion this thing, or if you want to tell your blood bank in your hospital, you need to activate MTP. So you need to send the baseline workup, coagulation, and blood gas. So what you need to optimize in a trauma patient, you need to optimize your oxygenation status, cardiac output. What you need to monitor, CBC, coagulation screening. You need to make sure you aim for more than pH of 7.25 so that your and lactate should be less than 4 and platelet should be more than 50,000 and PT-APTT try to get it less than. So it's a vicious cycle where the child will be bleeding, acidosis will worsen coagulopathy, child will be further bleeding. So you need to break the chain somewhere. So either you need to correct your acidosis. How you're going to correct acidosis? You need to correct the shock. How you're going to correct the shock? You need to stop the bleeding somewhere. So it's a vicious cycle where you have to break somewhere. So the point is either if you correct acidosis by correcting the shock, then your pH and base X will be definitely in control, lactate will be in control by weaning your blood products. So if you don't have blood products, straight away don't wait, you have to give O negative. So if you are feeling that FFP is required, if the uncrotched this thing is there, you need to give AB plasma. So to avoid sensitization and future complications, Rh negative PRBCs are preferred for females of childbearing age. As soon as it is available, you need to give tri-specific PRBCs. So we have done all this. Now the child is under control. We did CT scan, we did EFAST, everything is under control. So what was the cause from the GCS? Fall from 15/15 to 12/15. So we did a CT scan, which was showing subarachnoid hemorrhage with mild cerebral edema. So we had all these doubts. What are the indications for anti-epileptic drugs in TBI? So there are clear-cut guidelines. So, but before going to that, what are the indications for a CT scan? So we have clear-cut guidelines. Usually we follow the PCON criteria, Pediatric Emergency Care Applied Research Network criteria for head CT. As you can see, if the child is younger than 2 years, if you feel the GCS is 14 or any signs of altered mental status or palpable skull fracture, CT is definitely recommended. If not, if you feel even the history of loss of consciousness is more than 5 seconds or not acting normally as per parent, definitely you have to go for CT. You can't tell I not do CT. So these are clear-cut guidelines and indications. So if the child is older than 2 years, previously if they used to have any history of loss of consciousness, vomiting, or even severe headache, even they are indications for your CT CT brain. So when you have to start anti-epileptic medications, if you feel the GCS is less than 10, if there is skull fracture, if there is any bleeding, if there is STH, SAH, even intracerebral bleeds, or if there is any penetrating head wound, or if there is any cortical contusion, or if the seizure is within 24 hours of injury. These are all indications for anti-epileptic drug initiation. So if you feel the GCS is less than 10, even that is indication for starting AEDs, along with your depressed skull fracture also. So our child had a clear-cut indication. So we have given 3% NS because of the drop in the sensorium, followed by started the infusion. We have loaded the child with Levipil loading dose of 30 mg per kg, and we have followed by maintenance. So initial management done, we have cleared the C-spine, stabilized with collar, we have inserted ICD for breathing, SATs have picked up. Circulation wise, we have given fluid boluses, followed by blood products. Disability, we have given AED, 3% NS bolus, 5 ml per kg. So what next? So as I keep on telling you, you have to follow ATLS guidelines in that it's airway with C-spine control, breathing with ventilation. So we have cleared the C-spine, we have cleared the breathing part with ICD, we have made sure the blood products has been given along with circulation with control of hemorrhage, along with your disability. So now the child is comfortable, airway and C-spine are maintainable, breathing and ventilation is very comfortable, mild tachypnea is there, otherwise normal, circulation is, heart rate become normalized, CRT is normal, blood pressure is normal. So child is stabilized, vitals are normalized, so we have shifted the child for further PSU management. So every trauma patient actually must be reevaluated constantly to ensure that new findings are not overlooked. So usually we will keep on missing many cases where we'll be seeing initially presentation in the ER, followed by we usually check the child after 3 to 4 hours and we miss many findings. So we have taken neuroproductive measures, two-third maintenance. Respiratory wise, you make sure that keep PSU tells if you ventilate the child and make sure there is no role of prophylactic antibiotics. You need to target MAP of more than 50th percentile. You need to keep noradrenaline to maintain your cerebral perfusion pressure. Make sure your HB is more than 10 gram per deciliter in traumatic brain injury. Sodium wise, you need to keep more than 145 to 155. Abdomen, you need to give early nutrition. Neurological wise, CPP targets, adequate sedation and analgesia. Others, you need to maintain euglycemia. So what are the take-home messages? You need to follow ATLS protocol, airway with C-spine clearance, the role of EPAS scan. As I told you, you can make sure you can do pericardium, pelvic, perihepatic, and splenic regions. You need to involve the pediatric surgeon and orthopedics early in cases of bleeding for source control. And neuroprotective measures should be followed strictly in case of TBA. Thank you, everyone.
Thank you, sir. Thank you, sir. That was very informative and very precise discussion, sir. Thank you, sir.
Thank you.
Any questions from the participants?
Very nice, Balakrishna, but you skipped a lot of slides, I think, because of time.
Yes, yes.
So it should have been combined topic of pediatric surgeon and pediatrician, acute pediatric intensivist.
It has been a great learning experience for me. Really.
Really.
Thanks a lot for bringing me into this platform. Most popular platform. Thank you so much.
Oh.
I'm sure all the intensivists as well as the the cardiologists, those who have probably logged in would have been immensely benefited. Any questions? I think Rupa Madam can interact if there are any questions.
No questions in chat box, it seems. So, which ARBs are approved in pediatric practice, Jyoti Prakash?
Sir, actually, Losartan is the only one which is approved, sir. But Valsartan, as means many study trials are there. So we are of the label. We are using Valsartan also, and particularly yes. And when we want to combine with sacubitril, this sacubitril with Valsartan is available as Vimada and Entresto. So this the Valsartan with the sacubitril combination. Actually, the suspension also is supposed to be available. Actually, pre-COVID itself, it's supposed to be available, but because of some patent issues,
not as rescue medication, but it or maintenance. What I am talking, but yes, not for the rescue medication. Yes. In rescue, you can use anything. It doesn't matter for few days. But optimal management of heart failure in patients, that is more important. That is more being practiced now, yes, to avoid cardiac transplantation also, because optimal management will make a lot of difference in management of heart failure in pediatric practice. Because
yes, sir. The potential reason for not advising the angiotensin receptor blockers is mainly because they are not available as the suspension force, because many times only tablets will be available.
I'm not coming to the acute management, only for maintenance and optimal management. It is only acute management is only for few days.
Yes, sir.
Not more than that.
Both Losartan and Valsartan
because every patient will not come to the pediatric cardiologist during maintenance.
Yes.
Because they will be more away, and they will be with their pediatrician, and the message goes to the pediatrician, not the this. So, how far it is useful. CRT in pediatric patients. Have you, adult it is different, but CRT in,
Yes, sir. If we compare to adult versus pediatric, actually the criteria, whatever
not practical.
practically,
Practically
yes,
how?
sir. Practically, it is restricted to dilated cardiomyopathy only. Till now, whatever the trials has done, it is only for chronic cardiomyopathy where there is no other option left. It is CRT. So definitely there is significant benefit. Means it is helpful in cardiac remodeling as well as this one, but only it is available for about 20 kgs. Yes.
Dear Jyoti ji, I have a question.
Yes, sir.
Yes.
See, the caseload is so much in ICH when I was working there till 2018. See, now the government, government of Tamil Nadu has come out with a scheme that wherein we refer cases to the private hospital, the corporates, and the surgeons. Suppose those children with heart failure, indication for surgical procedure are shifted there, and rather the consultant who come to our hospital and operate upon, and they go away. This is covered under the CMHS, that is Chief Minister Health Insurance. How about in your state, Dr. Jyoti?
In our state, actually, there are two systems, sir. One is Aragyasri scheme is there. Then another one is RBSK, central government is one. Rashtriya Bal Karikramam is there. Both are there, sir.
That is the cases which are being diagnosed, picked up in the periphery,
yes,
referred, and being yearly we detect and then we treat.
Yes.
I'm asking about those children requiring a surgical procedure.
Yes, sir. The surgical procedures will be covered under Aragyasri.
Aragyasri program. They are doing free of charge here.
Do you have any system of hiring a cardiothoracic surgeon from private corporate hospital, MVS, sir?
No,
to
sir.
Bring in?
No. That facility is not there at present because it was there in previous, since long time in Tamil Nadu. They used to, even MMC also, they used to be honorary head of the department. And they used to admit private cases, and not that, poor cases, and they used to do it. But that system is not there in Andhra Pradesh. Only available is Aragyasri, and government, anyway, other government institutions are free. That's it. And till today, we don't have, till Padmavati Hospital is the only one which is established recently, full pediatric cardiac setup in Andhra Pradesh. In Andhra Pradesh, divided Andhra Pradesh, I am selling. Yes, sir. Apart from private corporate. That is only. There is also, he came from Tamil Nadu. He is only Telugu, but Ganapati Subramanian is the one cardiac surgeon who operates everything. In Padmavati Heart Institute in Tirupati. This is full-fledged one. At present, now we have pediatric cardiac surgical facility.
Dr. Jyoti,
sir,
do you have any incidents of particular cluster of cases of CHD with reference to post-COVID? For example, in adult, they say that they have increased coronary artery disease and so on and so forth. Yes. Similarly, in pediatric heart disease, do you have any cluster post-COVID?
Post-COVID, actually, I don't have the data, but whatever I read is like it's only 1% of the people, less than 1% is having the incidence out of COVID incidence, but because it is very milder form in children, pediatric age group, only the coronary involvement may be there, but that also, even if you don't treat, many times I have seen 4 cases where the patient is either not affordable for steroids or not IG also, but still they have resolution and follow, complete resolution without any coronary and sequelae.
So the missing children on vigil and being followed up for over a period of 2 years.
So, yes, sir. We did up to 6 months with center, pediatric centers in Vijayawada.
See, itself is a mystery.
Yes.
Yes.
So,
So is there anything else, sir?
Kishore, closing
Anything
remarks.
else? Otherwise, we'll wind up.
I will close, sir. Close the session, sir.
Okay,
Okay,
sir.
sir.
Thank you.
So thank you very much, sir. Somashekar, sir. And thank you, Rupa ma'am. And thank you, Jyoti Prakash and Balakrishna Reddy for excellent talk. And thank you, Suresh Babu, sir, the AP President, for participating, giving these valuable sessions. And I would like to thank all my central EB members and state EB members and my joint coordinators, Ratna Gatti, Tatam Naidu, and Satish. And thank you very much for joining and giving your valuable sessions, sir. Thank you very much, sir. We'll close the session, sir.
Good
Thank you.
night, sir.
Good night,
Thank
sir.
you,
Right,
sir.
sir.
Thank
Good
you,
night, sir.
everyone.
I feel as if I'm in Nellore, sir. Naveen,
Yeah.
Kishore, sir. Thank you.
Just it is,
Thank
you can fly 2 hours.
Thank you. Thank you.
Whenever
Good
you
night.
feel,
Good night. Good
you
night.
can come.
Good night.
Thank you.
Good
Thank you. Thank you very much, sir.
Thank you.
Thank you.
Good night, sir.
Next.
Thank you. Sir. Thank
Good
you.
night.
Thank you.